introduce to everybody today Jake Felly. He is the CEO of RX Precision and joins us today as one of our concierge clients. He's going to be sharing a general education for you on what exactly is precision pharmacy and what's the future entail. Of course, he has a crystal ball there in his room that he can share with us what the future holds. But Jake, I will hand it over to you, and we're excited about this call today. We'll have some time for Q&A a little later. And for those of you just joining us on the call, you'll notice on the right-hand side that there is a little place called questions. And there you can populate your questions, and we will be delighted to answer them at the end of the presentation. And look forward to your presentation. So, Jake, take it away.
Well, thank you very much. I appreciate the introduction, and definitely appreciate everyone spending time with us today. I'm glad you're getting credits for this at the very least. As Jenny said, my goal today is really just to give you an overview of what is what's going on in the genomic space right now. I'll do some kind of introductory things and give you an idea of what the differences are in the genomic offerings that are out there and what actually is important for us as fiduciaries and plan sponsors to be paying attention to when it comes to genomics, and what opportunities are out there that we might be missing out on, and how we might be able to take advantage of those. Jenny, how do I advance the slides?
So if you click your cursor directly on the slide, you can use your forward key or your backward key to advance the slide. And if that doesn't work, I will do that for you.
Okay, yes, I don't have control of it as it is.
I got it. Just let me know. Next slide, and I'll do it.
Okay. Next slide, please. All right, so the precision medicine ecosystem is really supposed to be built around each individual in a group getting what they need from a medical treatment. So as we see it today, we have all of the different players that are involved in the funding of healthcare, the delivery of healthcare. I think everyone since the human genome was actually sequenced back in 2003 believed that an individual being able to receive treatment based on their own genetic makeup was going to be coming quite soon. In all reality, what we have now is we have fantastic genetic science. We have the ability to sequence an entire genome in a very short and rapid amount of time for a very, very small amount of money. And relatively speaking to what it used to be over $1 million, and now it's sub 1,000. But what we have is we have great science, but we do not have buy-in and a systematic way of bringing the actual resource of precision medicine down into the patient experience. And that really is it's been the greatest conundrum in the risk management space for us, is why is there such an effective and powerful tool that is available to us? Why is this sitting on the sidelines when there's really been no better time in history to be able to utilize such a powerful mechanism to improve healthcare quality and efficiency? So what we found out was the major issue was that there was a lack of defined training tracks for physicians. In America, we have an incredible dynamic of different specialties out there, dozens of clinical specialties that physicians can train in. Then they can get into subsurgical specialties and fellowships and all of those types of things. But genetics is not one of those things that had a really clear path once a physician was trained, what we have is we have physicians who are normally a specialist in something else. They could be an immunologist or a rheumatologist or something like that. And if they have their own personal interest in genetics, then they may actually go and get some additional training. So we have a physician training issue. We also have major issues with the carriers, and we all understand the carrier world today. They're the ones who are administering your health claims for you. They are deciding what is in and out of network, what is covered and what is not. And genomics is kind of one of those things that came on the scene, and I think because of the lack of physician training and standardization in healthcare, carriers didn't necessarily know exactly how to look at it. They didn't know if the physicians that were actually requesting the testing or ordering the testing to be done, they didn't really know if they had a great deal of training. They didn't know if they had a great deal of expertise. So that in and of itself was a really big problem. Right now, really the general landscape is, no matter where you are sitting as far as your responsibilities, your professional life right now, genomics needs to be on your radar. It's not necessarily something that you need to engage immediately. We all have our initiatives and the things that we need for our plans to accomplish in the next year or two. But genomics is coming. It's coming quite quickly. And really what's most important is to make sure that when we look at developing a genomic strategy, that we actually look at developing it in the right way. So Jenny, I'm going to pause real quick because I am not entirely sure that this is the right presentation. Can you advance the slide one forward? And go one more beyond that. Okay, so no, this is not the right presentation. Can you share or allow me to take over the presentation? Because I have the right presentation up right here.
Of course I can.
All right, if you could grant me that access for just a short time.
Bear with us momentarily. Okay, you should have it now.
Got it. Okay, perfect. So let me get set back up here. Because of my travel, we'll just explain what just happened here quick for everyone's knowledge. Because of my travel, I was unable to transfer the presentation into the appropriate format for this particular thing. So I ended up sending Jenny a different format. That's the confusion. She ended up using the other slide deck that I had presented, which was more of a sales-based deck, and I don't want to present that one. So this is the slide that was intended for this use. Okay, so effective management in populations. So here's the different types of genetics. We have recreational genetics, which is what the vast majority of you have familiarity with. This is what you see being advertised today through the 23andMe's and the ancestries of the world. We don't mean we're not using recreational in a bad way. It's just it's important to understand that this type of genetic testing is something that the FDA does not regulate. It's one of those things that you can do it on your own. Your doctor doesn't need to be involved. And a lot of times the labs that are running these results are not necessarily always guaranteeing the accuracy of the output. So it's important to know that if you're going to go ahead and do one of those types of genetics testing, one of the genetic testing options there, that you take it with a grain of salt a little bit, and realize that even in the health outcomes and the prediction, health prediction testing that's done, health risk testing, that it's not necessarily black and white. And a lot of the times what you see in that type of testing, the outcome is not necessarily something that is going to happen to you, and it's dealing with a portion of the genome that is commonly changing, or it's constantly changing based on lifestyle and environment and other factors. So just keep in mind when it comes to recreational genetics, that is not necessarily the type of genetics that we're talking about here. Again, kind of a consumer beware type of thing. Do understand that when they get your information, they will use it, and they will use it for whatever they want. Some of you may be familiar with a recent multiple $100 million deal that was signed between a very large pharmaceutical company and 23andMe to share their information of all the people that they've sequenced over the next 5 years. That's a good example of making sure that you're aware, if you're going to send your information into those companies, that they are going to use it, and just make sure that you know that and that you're okay with it. So a lot has changed in genomics. As I mentioned before, in 2003, since we sequenced a genome, it started out with it taking months and months and months to actually sequence a genome, and millions of dollars to do so, to now the testing is very brisk. It's very, very accurate. The great thing about being able to start looking at genomics in healthcare is it really spans all of the areas of concern, all of the areas that are relevant to us in our professional positions today, looking over health plans. This is something that is able to touch and influence every one of those areas. So obviously, better disease understanding, more accurate diagnostics, and tailored treatment is what we kind of all want. And it doesn't take a lot of thought to understand how those things could actually impact our health plans in a really, really positive way, and really improve the lives of our members and employees dramatically. So I think the first step in deciding what we're going to do with genomics is really to understand what testing is actually useful when we're trying to manage risk. So our first question is, does it change how the patient is managed by the physician? If a genetic test does not give immediately actionable information to a provider, and it can influence the treatment plan immediately, then there's a big question mark in our mind if that's something that a health plan should be paying for today. No other place, in no other area in medicine do we fund things that could potentially do something or influence treatment 20 or 30 years down the road. We're paying for things right now. So from a health plan perspective, obviously employers and so forth are investing in wellness initiatives and things like that, and that's great. But when it comes right down to it, we are focusing on medical treatment, and that's improving outcomes, quality of life. From an employer perspective, am I getting more productive members back when we're making sure that treatments are tailored to someone's genetics? And then family members as well. For those of us who have dependents on our health plans, we're not just managing an employee anymore, we're managing an entire family. And we all know that spouses and dependents tend to cost us more in the health plan than just the employees. So we have to look at it in a global perspective. So some of the highest cost drivers, I think you guys are all aware of these. Cardiovascular, oncology, and diabetes are the big ones. Specialty drugs interwoven into these diagnoses areas, as well as getting into autoimmune disease, would be the other driver. Not quite hitting this level yet, but I think we all know it's climbing so fast that it probably will be in the top three within the coming 5 years. So I think a lot of times the question is, if we're going to consider genetics as a tool to be used in our health plan, we need to make sure that it's hitting the highest cost drivers. And that is one of the things that is, in our opinion, the most important, is if we're going to start a genetic approach, if we're going to start a genetic strategy, let's target the areas in the health plan that we're really, really, really already very desperate to find solutions for. So clinical and diagnostic genomics. This is the area of, oh, yes.
Sorry for interrupting. Just so you know, I'm trying to figure out your screen, and what I'm seeing is the open PowerPoint, but it's not sharing with everyone. I see just one slide. If you give us power or keyboard access, our IT tech can share it.
I think, can you see it move now?
I can see it moving now.
Okay. It wasn't agreeing with my presentation view, so I will just leave it on this view, and we'll go through it this way. Okay.
Okay. Thank you.
Yes. So here we are at Clinical and Diagnostic Genomics. Sorry, everyone, for that technical snafu. This is what we get in the real world. We're live. Okay, Clinical and Diagnostic Genomics. This is the area of genomics that we believe very strongly. This is what health plans need to be using and utilizing. It has a great deal of promise in being one of the most effective ways to manage high risk and highly complex clinical cases, and those are all the cases that are spending the most money of the most plan assets. Usually it's a very small amount of our population consuming the largest portion of the plan assets. And that is specifically, those are the areas that clinical and diagnostic genomics shine. So when it comes to early detection of disease, that is not the number one goal of implementing a genetic test. We want to make sure, because early detection of a disease process is very difficult to do with genomics. As we all know, that if there's not a symptom there, it's very difficult to order a test for something other than the types of tests that are ordered in a yearly physical or something like that. So, but adjusting medical management immediately, as I mentioned before, that has to be one of the number one goals in any health plan's planning strategy as to how to implement genomics. Reducing variables in complex cases. We always talk about removing variables or reducing variables in clinical cases being one of the most valuable things in medicine. When you get in high risk and high cost populations, they are ultimately complex. There's multiple physicians. There's a lot of times over a dozen medications being prescribed. And if it's not that many medications, usually the medications that are being prescribed are high-powered medications. They're high risk. They're highly potent. Decreasing adverse drug reactions. A lot of people don't know that adverse drug reactions are a very high cause of death. And over 100,000 people die every year. I think the number is getting close to 150,000 people die every year just from drug reactions. That's not even the people who are just harmed from them. Those are the actual deaths. The number that are harmed are quite a bit more than that. So decreasing step therapies and trial and error prescribing. Obviously, health plans don't want to be spending money on a drug that isn't ultimately going to work. So if you can just eliminate the steps of going through multiple drugs in multiple months to finally get to the right treatment, if we can just get to that right away, I think everyone sees the benefit in that. And then risk of sudden death, which is not everyone wants to reduce the risk of sudden death, but it's not a major component of health plan spending. So the others that are before it are really the main focus. So here's just a quick visual on pharmacogenomic testing. Not every person reacts the exact same way to the medication. We are dealing with, each of us have a portion of our genetic code that is responsible for the breakdown and metabolization and detoxification of active drug ingredients. That portion of our genetic code does not change. There's a really large portion of our genetic code that does constantly change and is modified day to day, week to week, month to month, year to year, based on our environment. And that's how it's just amazing how the human genome actually works, and how amazingly flexible it can be, and how it can adapt and change over time to help us live the best life possible based on our situation. But the portion of the genome that we're talking about here is a portion that never changes. You either have the ability to metabolize a drug ingredient based on your genome, or you don't. And you can be somewhere in between there where, yes, you can metabolize it, but as you can see in these visual examples here, some of us may need half of the original dosage, and some of us might need twice as much of the original dosage to get the desired clinical effect. Jenny, just want to double check. Can you still see my slides moving?
Yes.
Fantastic. Okay. All right. So I think a lot of people are asking, well, what is it that this is going to do? What's the clinical information say? What type of ROI can we expect? So I want to go through some of the research that is out there really quickly, just in some of the diagnostic areas. First of all, psychiatry. I think we all know mental health is one of the greatest concerns that we have in health plans today. And not just for the health plan spend perspective, but also what mental health and behavioral health can do for someone's productivity in the workforce, and how detrimental it can be for an employer to have people with mental health or behavioral health issues not getting the desired outcome in their treatments. So you can see here that depending on poor or ultra rapid metabolizers, as I mentioned, a poor metabolizer before is someone who cannot metabolize a drug as fast as normal. So what happens is that drug builds up in the system over time and creates toxicity and other problems. And an ultra rapid metabolizer is obviously, it's pretty self-explanatory, but it's someone who's able to tear through that active drug ingredient so fast that if taking a normal dosage would not have any effect at all, almost as if you're not taking the drug. So we obviously don't want to be paying for prescriptions that people are swallowing and having absolutely nothing happen. So that would be the benefit here. When you look at what happens with medical costs and disability claims, sick leave days, how dramatically increased those are when we find people in a population who have issues, behavioral health is definitely one of the greatest areas of opportunity for pharmacogenomic testing particularly. Pain management, this is a big one as well. Pain management is usually, it's not expensive as it relates to pain management drugs, but we all know, and specifically from the presentation before, we know that this isn't just about what pain management drugs are costing us. It's about the other things that pain management drugs are causing in our health plans. So being that we already touched on this one earlier, from a genetics perspective, pain management is just one of those things that it's much more efficient and it's much more effective when it's used appropriately and when you know that the patient is able to metabolize the drug the way that it should be. Oncology, this is just a quick idea of what happens in an oncology case when a drug is metabolized differently. So in this patient particularly, you see the cancer drug, you see the normal DPYD gene. This is 20% of the original dose of what they would give to a normal patient if they were just to start an average patient on treatment. And you can see from an effectiveness standpoint, the goal when you're treating cancer is to kill cancer, not to kill the patient or their healthy cells. We want to maintain as many healthy cells as possible. But you can see in the lower example that if that patient that has a mutated DPYD gene, that if they were to give that patient the standard clinical dosage, this patient would have a significant reaction to this type of chemotherapy, and it would delay treatment for weeks because a lot of times these types of patients have heart failure, they have strokes because of the healthy cells being killed. Sometimes they're not that dramatic, but the patients are usually, it takes weeks to recover from a reaction like this. So this would be a really good example of how genetics can be applied in our populations and how it's effective. This is just a quick summary that showed some of the ROI in some of the research that's available out there on PGX testing, pharmacogenomic testing, different therapeutic areas, different focuses, and some of the control groups were really small, but some of them were done really well. All of these studies were actually designed quite well, but they only studied a really short time frame. And if any of you have members on your health plans that are there longer than a year, then you need to start looking at genetics as a multiple effect, because the longer your plan member tenure is, the greater the impact that genetic testing can have on you, on your plan, the sooner you start it. Just want to touch on this really quick. It's in our belief that the medical community today needs help with this subject. Most doctors are not comfortable with it, they're not trained in it, and that's why it's not being used. So we make sure that we bring in genetic specialists to be the peer-to-peer support in this situation, and make sure that when we actually run one of these panels, that it actually gets put into action. This is another big one. There's so many tests that are available. A lot of times employers that we've worked with or health plans that we speak with, the question is, what tests should we be using? What labs should we be using? And that's something that we believe very strongly is making sure that you're able to narrow it down to using the right testing at the right time. It's basically setting up your genetics plan to be precision in and of itself. And this is just to get an idea what our population is and how few genetic experts we have. It's definitely, it can be challenging to find the right people to do something like this, but from a perspective of a health plan, it's definitely worth the effort. And we are, fortunately enough, we are now in an area where we can do this in a very scalable fashion. So even if you have a large health plan, there's only a portion of the people within your health plan, under 10% normally, that really would benefit from this and would be able to show a dramatic ROI to the bottom line when you implement genetics. So we are talking about a smaller amount of the population here, but very, very powerful and impactful. Okay, Jenny, I am finished.
Thank you so much, Jake. What an excellent presentation. And I think it brings to mind a lot of questions that employers have about rolling something like this out as an option for their employees. We had one person ask the question, if they wanted to roll them out, what are the ways that the employee gets information about their genetic testing? So let's say you add this for an employer, they decide to add it for their, maybe their high-risk population. How does the employee deal with the information and tell their doctor, and how is that done? And I know you mentioned peer-to-peer recommendations, but
yeah, that's why it's important that the process has to be facilitated with clinical experts, genetic experts involved, because a patient, even a very well-informed patient, can't look at one of these reports and do something with it. You can get a general idea of what it means, but even some physicians don't know how to interpret all of the results. So it's important when globally, when you're putting a program like this together, that the peer-to-peer piece of it is not missed. That has to be a portion of it. The great thing is this pharmacogenetic information is good for the rest of the patient's life. So they can always keep that information in the EMR, the medical record, and the patient can take it with them to whatever physician they need to see in the future. But when we manage it for health plans, we make sure that that we have the right experts in place when that information comes out.
Okay, and how is that communicated? Is it communicated direct to the employee? Is it communicated to the employee and their physician? How do you typically roll that out?
We always give it to the physician first, because we all know that patients have a way of trying to change treatments for themselves sometimes. I mean, we hope they don't, but our fear is if we send the information directly to the patient immediately, that they may see something on there and try to start taking themselves off of medication. When we send the results, we send them to the physician, and we immediately get the meeting scheduled, the consult scheduled for the physician and our peer-to-peer expert to meet with that patient and make sure that we get those changes made right away.
Awesome.
And then the patient takes that information with them from that point forward.
One employer had also asked, what are the cost constraints for this? If they've already, say, done their budget this year, how do they add something like this, and how do they roll that out to their population?
Yeah, the beauty about and this doesn't apply to everyone who's doing genetics for commercial populations like we are, but in our case specifically, this is a medical procedure. So we bill the health plan. As long as you have premium dollars in your health plan, then we can launch something like this. You don't have to have a separate administrative budget. This isn't a PM type of conversation. It's a case rate that is bundled. It is all inclusive, and it's only billed once someone actually receives testing. So that is what your premium dollars are there for. Everything that you've paid into your healthcare fund is for medical procedures and diagnostics and those types of things, treatments, and that's what this would be taken out of. Also, I would say from a pilot perspective, we haven't used the word pilot enough. I haven't, sorry about that. But a pilot perspective, we don't need to go after the entire plan. You don't need to have hundreds of thousands or millions of dollars to launch something like this. We can do it in a smaller way, in a more calculated fashion, and do it more of a phased approach. What does pharmacogenomic testing look like in our population today? What will it look like next year and the year following, depending on the results that we get in the first phase?
And do you and your teams have recommendations for employers and brokers that are looking to roll it out, say, in a pilot phase? Do you look at, the highest risk population and say, let's look at this particular illness, or are you trying to look at kind of across the board? How are you doing it, or is it just based on each employer?
Every employer is probably going to have their own top 5 or top 3, and maybe even their top 1 or 2. If you can isolate those are the areas you want to go after. You want to use your phase 1 genetic approach should be building your first pilot or first 2 pilots around the most emergent disease issues that, if you're a leader, or if you have C-suite people that you report to, they're on you every day about that particular area of spending or that particular area of risk. Genetics can be tailored to any area of medicine, and it's a lot less of a gamble for a health plan sponsor or a fiduciary to implement a phase 1 genetic approach when you're doing it on an area, a clinical area that you're already struggling to find results and already, scrambling, trying to control costs.
Awesome. What about this was a question that came up recently. Okay, so we find out an alternative drug is better, but it's not on the formulary. You put it on the formulary. Yep. That's what somebody said.
Well, that is when you get to make decisions based on what you know, not what you don't. And I think that's really the most important thing here is now that we know that this patient will respond to this particular drug, then you can potentially make a case-by-case coverage decision based on a clinical outcome you're looking for. Right now, the problem is we don't have that type of information, so we're normally making formulary decisions or coverage decisions based on cost of a drug, not necessarily individual efficacy.
Right. Well, this has been really informative, and I think, as I mentioned, we have had a good half and half group with brokers, employers, and C-suites on the line, and appreciate you taking the time to answer some of these questions. And we could definitely let them. And by the way, we can't get to everyone's question because we are at 5 o'clock and a couple minutes after. And so what we'll do, though, is we will get information to you about the onboarding process, what a pilot might look like. Those questions that we're getting, we can definitely get information over to you. And we'll be having this conversation with Jake and others throughout the year. I want to thank everybody who's attended this year this month, and know that we'll be having monthly webinars, virtual summits just like this, where we bring information like what Jake just brought to the table, which is a real learning curve for a lot of people. You just haven't had the conversation. Doctors don't know it, so they're not talking about it, and therefore, it's the people like Jake and others that are bringing this to the table and helping people understand it. So really appreciate you taking the time, again, during your busy schedule and travel, to give our audience information that is, vital, I think, for precision care. And I've said this before as I personally have had trouble with getting the right medication for my child, and, went through lots of days off and, just tons of challenges with her side effects. And now she's doing good, but had this been an option for her, it would have saved countless hours of time off. And so I'm excited that, it's real and it's out there and it's available, and it makes sense that we would want precision medicine. So thank you, Jake, and thank you all for attending. And we will be sending out an invitation for our next webinar, and we'll be giving more information just like this. And Jake will be back with us as well, hopefully soon.
Thank you very much.
Thanks, everyone. Have a great day.